right. Well, thanks for having me. It's actually very much an honor to be here and spend some time with you guys here in New York City. It's probably my favorite city on earth, and even more so getting to hang out with Luis a little bit and Bill. Even though Bill and I live in the same city, we tend to only run across each other when we're about 3,000 or 4,000 miles away from home. So, and these are gentlemen that have really pioneered the surgery I'm about to talk about, along with Dr. Behrouz Akbarnia, who's my senior partner. Anyways, just again, thank you for having me and for allowing me to share this morning, or this afternoon now. For me, it's still morning. We just flew in this morning. So here are my disclosures. So what we're about to talk about, let's see if I can get the sound going. Is there a sound button here? So I'll just, there we go. So basically, a lot of people think ACR surgery is a little bit like this guy, where it's only for the select few, no one can do it, it's so hard. It's just a really hard way to do something more simple. The bottom line is, hopefully I'll show you after today, there's a long track record of what we're doing, and hopefully I'll give you a little bit more confidence that this is a technique that, when done safely, can certainly be used in your practice. So hopefully we'll make that call for you today. That is not at all what an MIS TLIF looks like. Okay, so I actually have a lot of canned talks about ACR, and this one actually brand new. And so I'm actually excited to share. I just finished it like 10 minutes ago. I put it together a little bit differently, because I put it together a little bit like train of thought rather than here's just to talk about the procedure itself. And so I basically used a timeline to kind of walk through how this procedure was developed. I know I'm going to miss stuff, and Luis is going to come up afterwards and nail me for it. But please, Luis, fill in gaps afterwards, because you've been instrumental in so many of these. So this is Dr. Akbarnia's patient in 2005, and he was doing a lateral surgery, and he sort of serendipitously would say released the ALL, and something very interesting happened. And where he thought he was just going to do the front part to release and do some fusion, what he realized when he did it, he got about a 50-degree change in the segmental alignment at one disc when the patient had a segmental kyphosis. And this sort of sparked a thought in his head, like, oh my goodness, this could actually be something more than just an interbody fusion. Perhaps we can really treat sagittal plane deformity with this. And so this was sort of the first case that got our tail spinning. Sadly enough, this patient actually has a C2 to pelvis now, ultimately. But I think interesting in the sense that we realized there may be less invasive ways to do this operation. So we're going to skip ahead for a year, and this is when Bill and Luis published this paper. And this was a landmark article. It's one of the most highly cited articles, and it involves just describing this approach from the lateral transpsoas, and really was instrumental in saying there's a safe way to get through the psoas to do an interbody fusion with a large interbody device. A lot of the data that came out of the next 3 years, and we're going to skip to 2009, was really centered around the lateral approach more than it was centered around any type of deformity correction. There were a few little deformity papers in there, but nothing really looking at the sagittal plane. And in the meantime, what was happening is that these cases were happening. And I did my fellowship in 2008. This happened in 2009, still during my fellowship. One of Dr. Akbarnia's patients that I helped treat, but we recognized a segmental problem here. The patient had some segmental flattening. You can see the PILL was off, the SVA was off, and if you look closely on these scans, you can realize, all right, there's dynamic spondies, there's error in the disc spaces, and this patient has flattening from L4 to S1, and it needs to be realigned. We did that through TLIF at L5 S1 and then a 4-5 ACR, which is not at all how we should treat this nowadays, but recognizing that this was one way of doing it. This then grew, and this is one of my early cases. And this is his post-op films. This then grew into the next sort of sequence, which was, okay, if we can do it at one level, maybe we can do it at multiple levels. And so this is also 2009 still. It's one of my patients that had a previous 4-to-1 fusion, has some thoracolumbar kyphosis, but then has a fairly high PI at 71, needed to accommodate at least 30 more degrees of lordosis. This SVA was grossly positive, and so I thought, hey, instead of doing some more invasive corrective maneuvers at L4 or L5, like a PSO, let's see if we can get the rest of it done just by doing multi-level ACRs above it. So we did 3 of them above that. Notice only 1 screw in each of these, and I will address that a little bit later on in this talk. And then here's what he looked like in between stages. Got it better, but not totally right. And we decided to do a long posterior construct to fix it. And this is what he looked like immediately post-op. And mind you, was actually very happy for about a year, and then took a downhill turn over the course of the next 2 to 3 years, and ended up actually in year 3 breaking his rods and needing a revision. So we go ahead to 2011, and we're getting a little bit more confidence in these procedures. Still not really any publications on this. So these are mainly just clinical experience that's happening before this time. Mind you, we're about 8 years ago now. And so this is a patient that came in, multiply operated, and see the mismatches that exist here. A patient has actually lordosis in her lumbar spine, not even kyphotic. Sorry, not lordotic at all. She's totally kyphotic in her lumbar spine, and has a significant mismatch with the high CSVL. And so this is the first time that I was able to document this via video. And so I've shown this video quite often on how to do an ACR. And basically the way I think about it is I do a regular lateral, and then at the end we just cut the ALL and then dilate it up and then put in a larger lordotic implant. And you can do it at 1 or multiple levels if you need to. And then you can see just the same process happening here. Mind you, I'm a minimalist when it comes to disc prep. I use the cob a lot. I hardly use the pituitary at all. I use a box cutter, and you saw the knife just go in there, and this is popping it open and then placing the inner body again. At this point, still using 1 screw, and I'll talk again about that here in a little bit. So this is what this patient looked like. This is what she looked like after her stage in between, that had her final construct there on the right-hand side. Mind you, it's not a standing film, but there's a reason for that. And I don't see it on my slide here, but maybe it's coming up in a little bit. I bet it's coming up. I'll show you the end result, which again led to a revision. Because our understanding of this implant really wasn't mature enough, and the understanding of the sagittal alignment wasn't, I believe, mature enough. So this is sort of our first attempt at bringing something to the academic circuit. So this is a poster at IMAST, showing us our first 17 cases. It took us a couple more years to end up actually publishing it. But that, at least we were making the attempt to collect our data and go from there. In 2012, we really started training surgeons a lot more. It's Dr. Kleinberg, Alex Shen from, at that time, from UC Davis, as well as University of Washington, coming down to train with us. So we were starting to grow and thought maybe we can use these ACR techniques not only for sagittal realignment, but maybe it's more of a global realignment. I thought I had 20 minutes. I don't have 20 minutes. Oh, this is a much longer talk. All right, so we're going to blaze on ahead here. So here's our intraoperative x-rays there. And so mind you, now we're sort of treating 3-dimensional deformity by releasing the anterior spine. And here's the pre and post. This led to a few more analyses where we're looking at finite element to see what we can achieve. This led to Luis's first publication. I believe this is the first series that was published through the HSS journal. And then Dr. Uribe following that pretty quickly after that, and then our series a little bit later, presenting our first 6 years of experience, again showing a substantial correction in the sagittal plane, but also reporting our complications, which happen about 50% of the time. And here's a full list of those complications for your perusal. We also presented this to the ISSG and said, listen, how does this compare to PSOs? So we did a study looking at PSO versus ACR, and this is that published report of that. We took 17 patients that had ACRs, 17 had a PSO, and we compared the two together and found that overall the ACR from an angular correction had very similar results to a PSO, and ultimately they did about the same. The ACR had a little bit better pelvic tilt correction. The PSO had a little bit better overall sagittal realignment. And then we published this several years later in 2017. So again, here's another patient that had both a segmentally kyphotic as well as scoliotic deformity, releasing it here and then having a good postoperative result. Leading us to 2014, we start looking a little more detail biomechanically. So we started doing some finite element analysis here and realizing that Well, if we put certain different degrees of cages in, we get different amounts of correction. So a 20-degree cage can give us 10 degrees of correction. A 30-degree cage can give about 20 degrees of correction. Now, that's based on finite element analysis. We decided to do a cadaver lab along with it and see what happened with that. And you can see here that when you don't release the posterior column, you don't get that much correction. So that's the bottom line. You can put a huge implant in the front, but if you don't release the back, you're just not going to get that much out of it. So this is just showing that segmentally here with the lordosis angle measurements, as well as the posterior disc height. The bigger the disc height, the bigger the correction. So here's a 77-year-old male who had a failed L3 to S1. This is what he looked like before surgery. He was actually a previous SRS president. Here's his numbers. This is sort of how we plan these operations, so it's good to kind of see our thought process. We fix the pelvic tilt first, then we plan it. This is what it would look like with an L3 PSO, which actually looks pretty good. This is what it looks like with an L1-2 ACR, and here's the 2-level ACR, and that was what he kind of would need. I told him you need to have a PSO, and he said, I'm not coming to you to do a PSO, I'm coming to you to do an ACR. So I said, all right, let's try it out. So here's the correction that we were able to attain on the table with a 2-level ACR. Here he is in between stages, and then here he is with his immediately following the second stage, and then here he is 3 years post-op having a durable result. 2015, we're going to more severe deformities. Mind you, I think the best thing that Luis said today is poor patient indication is the best way to have bad outcomes. And this is a patient that was on way too many drugs, had way too many problems to begin with. We started using the 2-screw technique here, mind you, having a nice correction. I showed you these actually a little bit before as well, but unfortunately, if you look here, we end up having to revise her because we built in way too much lordosis. She got PJK acutely, and we had to fix her there. So again, understanding where lordosis needs to happen is absolutely critical. So we decided to do a multi-center study here, looking at 4 different centers, pulling our patients together, realizing that across the centers, we were doing a pretty good job getting somewhere between 20 and 30 degrees of correction per ACR. We looked at our risks in 2017 of having these. I skipped the case, but just to realize that the lordosis correction, PLL mismatch improvement, and pelvic tilt were all durable over time, but also to show that the motor weakness that we saw early after surgery actually resolved in the majority of our patients, and the sensory changes that happened in 20% of our patients actually went down to 0% at 2 years. So these are at least data that we can use with our patients, showing that we have good radiographic improvement and that the neurologic issues that we have are typically self-limited. In 2018, we came up with a classification of ACR, and just to run through these real quick, a grade A basically means you did the ACR with no posterior release. A grade 1 basically puts a Schwab 1 osteotomy with it, which is basically a facet release. Type 2 is a facet resection along with your ACR. Type 3 and 4 is with a grade 3 and a grade 4 PSO along with it, depending on what you need. And this is this case where he came in before surgery, looked like that, had a non-union at L3-4. We went in from lateral, took the TLIF out, did an ACR, flipped him, and did a MIS PSO. And you can see this whole case was done through basically percutaneous approach. A type 5 is when you do a corpectomy for the purposes of your ALL release, as you see here, which kind of brings us up to date. Where are we now? And so a lot of what's happening now is biomechanics and trying to understand really what we need to do here. And so the group out of BNI has been very instrumental in showing us what we need. But basically, 2 screws are absolutely necessary when you do ACRs. Ultimately, if you really want to do it right, you should use a 4-rod technique to put the lowest rod strain on your construct. You can even do this minimally invasive, so you don't have to necessarily open them up to do that, but just realize a 4-rod construct is much better. The Italian group here, also another Brazilian group, showed us that the biomechanical strain here with an ACR is best treated with multi-rod construct. This group here recently out of combo out of BNI and Pittsburgh showed us that their PJK rate with ACR was 20% and their PJF, or so revision rate, was about 11% for these patients. And they realized basically that the PJK increased with crossing the TL junction, sagittal imbalance severity, and overcorrection in the elderly. And when we overcorrect these patients, they just have a tendency to topple over. So here's our first report of looking at patients that had both ACR and a PSO. We did it both in cadaver as well as in clinical model, but the bottom line I want to show here is that we had very substantial improvement in the sagittal plane deformity by combining the 2 approaches. So when you need to, combining ACR with PSO can be very, very effective. Just realize that these are very invasive operations, even if you're doing them through smaller holes. And then looking at rod fracture rates, we've now identified that we even get rod fractures. This is just that 1 year, you have about a 4% rod fracture rate. So this number is only going to climb as we follow our patients out. So just to finish it up, here's a patient, 72-year-old female, 3 previous fusions, complains of both SI and back pain. It's kind of what she looks like, has air under disc at L1-2. You realize that she has a lot of mobility at that 1-2 joint and with some end plate irregularities. Basically, again, what we do on these patients is we take their pelvic tilt, normalize it according to the pelvic incidence. So she ought to have a more normal pelvic tilt, like a 15. So we do that, and you realize that she's actually hiding her sagittal plane deformity quite a bit. That's what a L1-2 ACR would look like, but that's actually not what happens, because an ACR never fixes the pelvic tilt. It only changes your overall postural alignment. So this is actually what would happen, and we definitely do not want to create that, which is all the PJK I showed you earlier in the talk. It's because we're doing upper lumbar ACRs and not creating our harmonious spine. If you do an L3 PSO, it sort of looks like this. And so we end up doing is something, it was a little bit of a combination, which was we did an ACR at L1-2 to neutralize the kyphotic segment, not to do a full release. So this was on that grade that we use is a grade 0. So it was an ACR only without a posterior release. Basically what that did is it neutralized our segment at L1-2. It didn't really affect the flat back at all and didn't affect the tilt. And so then we go to the back and we do the MIS PSO, just kind of showing you how we do it. We get our anchors placed first with wires, do a midline approach for the PSO portion of it, where you can do relaminectomy and facetectomies, and then place your spoon retractors if you like those. I don't use them anymore. But you can place them there and then use a box cutter to actually do the osteotomy. Place your temporary rods that end up being the small little rods that sit deeply to your deep ones. Finish the PSO off, compress it down, and you get something that looks like that. We get your angular correction. And then basically you want to make sure you measured out and achieved the lordosis that you were planning for. Finish placing your anchors, pass your other rods, and then you'll end up with something that looks like this with multiple stab incisions on the back. And here she is at 3 months post-op. So with that, I guess I'll just say we don't want to be like this guy. You want to have a good team around you. When you're approaching these operations, you want to do it thoughtfully and carefully. You don't want to have any hiccups in the process. This is the first time you're doing an ACR. You sort of feel like this. You're on an island. You're alone. You don't have anybody you're talking to, and so you gotta make sure that things are right. And so if things aren't right, you need to reset and start over again, because otherwise this whole thing can end up very, very poorly for you. So with that, I want to thank you guys. Sorry for going over a little bit, and appreciate your time.